the reason why I chose this particular topic was at the moment I'm working in neonatal transport, so I thought I can give you some first-hand experience of a service that is doing dedicated neonatal transport. And wait, this, how does this go? This one moment. Okay, yeah. So I'll talk a little bit about how a service that is doing sort of purely neonatal transport works and what the principles are of that service. And then I'll go on to talk about the special stages of a retrieval, then some special situations where how we transport neonates with different conditions. And finally, I'll go through 3 case scenarios. So in these case scenarios, I'll try to do it a bit interactively if possible. So there'll be some, like I'll give you the case and then give you all the opportunity to think about it. And if you can, just even on the chat to mention some answers to the questions. And if you have anything to ask, you can send it through the, you can text on this, right, Dinushita?
Yes, madam, they can text it.
Yeah, okay.
On the chatter, they can text.
And then I can see it on the screen, is it? Or?
Yeah, otherwise I will read it for you, madam.
Okay, okay, thanks. So a neonatal transport or retrieval service is something that specializes in transporting premature sick newborns to centers with a specialist neonatal intensive care facility. So this involves not only the personnel who are skilled in this, but also quite a lot of infrastructure development also goes into this. So the basic idea is that you have a team in a central place which you can send out to even the smallest regional district hospitals who have the skills of a neonatal intensive care unit. So now in Australia there are like several states, and currently I'm working in Victoria, where Melbourne is the central place where the service is, and there are 4 main hospitals there. So those are the hospitals to which you bring these babies back, and it's quite a vast, I mean, Victoria is the size of Sri Lanka. So there are hospitals in very small towns. Some towns are not accessible even like by road. It will take 5, 6, 7 hours to get there, some of them. So there are some places where you have to go by plane or helicopter or wherever as well. So the idea is that within, say, maybe 3 hours or so maximum, you can get a team which has neonatal intensive care skills and facilities out to a baby who might be like 27 weeks or something. So in addition to this, usually retrieval service offers this as their main component, but in addition they also offer a consultation service. So some of the smaller hospitals, sometimes there are only midwives, sometimes there are GPs, or there are some obstetric trained GPs as well. So, or even pediatricians who don't have much experience in neonatal care, so they can always call and get advice as well. And we also do the return transfers. That is when a baby is well enough to go back to these peripheral hospitals, we take them back as well. And in addition, the main bulk of the outreach education, like the NLS we do, where like even in Sri Lanka, where we would go to, say, Jaffna, Batticaloa, Trinco, wherever, and do NLS. In the same way, that NLS service is also provided by the transport service. So the structure actually differs. Yeah. So the structure will differ according to the resources. Like now in some states they have the people working would be purely doing the transport, but in some states like Western Australia, some of the doctors would be working in the main neonatal intensive care unit, and they might get a call and they have to go out. But the service in Melbourne, which is the doctors and nurses, everybody is completely separate from the neonatal intensive care unit. So they are fully for the transport service only. And there are some who would work at a different time in the NICU, but not during the same shift. And it involves a lot of infrastructure development. So there's a separate office, equipment, ambulances, and in addition to the ambulance, we have the backup of the air transport service, which provides the planes and the helicopters. So staff-wise, there would be the director, administrative consultants, and then the retrieval clinicians, which are doctors or nurse practitioners, very experienced nurses. So these nurses generally do sort of part-time at the transport service and part-time in ICU somewhere else. But they are very experienced, especially in handling the equipment and all, because actually the doctors keep changing every 6 months because of their rotations. And by the time you get to know how your ventilator and things work, you have to change. So it's the nurses who have a huge responsibility there. And then you have the ambulance drivers, paramedics. They are also trained, most of them are trained paramedics. So the team you usually have would be the doctor, nurse, and the driver, who is generally a paramedic, who say you go to some place and you want them to find a ET tube, laryngoscope, anything like that, you tell them, they can find it from your bag and give it. So they categorize the retrievals into different types. There are the emergency ones and the non-emergency ones. So emergency, like time critical ones, you're supposed to leave your base, that's the hospital office, within 15 minutes. So these are the ones, say there's a very sick baby who is in shock, or a under 28-weeker who has just delivered somewhere where they have no facilities. And the primary urgent ones are the, say, a baby who is deteriorating with increasing oxygen requirement or something. And then you have the electives as well. Even babies who are transferred from one hospital to another for ROP, laser or something will also be taken by the retrieval service. And then the returns, as I told you earlier. So as you can understand, you sometimes end up in a very small hospital which has never seen a preterm baby, with just 3 people, the nurse, the doctor, and the ambulance, the paramedic. So it is very important that you maintain good communication, especially with the rest of your team and the referring hospital. And in transport, unlike in NICU, you do the minimum number of procedures to make your transport safe. So say in a NICU, if a 28 weeks, not 28 says, yeah, even a 28-week baby is born, you would want to intubate, give the surfactant, put the umbilical lines, do all those things. But in the case of transport, if the baby doesn't immediately need the umbilical lines or something, and you can manage with peripheral lines, because you have to think of the time as well. If the main hospital is, say, within 1 hour, you wouldn't waste time doing umbilical lines. So, but on the other hand, a baby you might manage its CPAP in a neonatal in an ICU, you might have to intubate because it won't be safe to transport in a plane and have the baby deteriorating in the when you're in there. So it works both ways, but it's different to what you would do in a NICU. And the other thing is you need to be prepared because of this, because you will be in an unfamiliar place, in difficult access, you don't have much backup, and also you have to be conscious of time, because sometimes you're, especially the furthest away places, you're taken there by the in a helicopter or plane, and they are the same service that covers all, say, road traffic accidents and everything. So they don't want to spend hours and hours with you stabilizing a extremely preterm baby somewhere. So you have to think of what is absolutely necessary and then try to do it safely and quickly as possible. And the other most important thing is you have to remember some things might not have been done very correctly in your standards by the referring team, but never ever criticize, because for them it might be the very first time they're ever seeing a baby less than 30 weeks. So the teamwork, communication, everything has to be there, because you're in unfamiliar territory and we have to do the best for the baby in the circumstances. So a little about being prepared. So there are a lot of what you call boring things we have to do every day. You have to, every shift or so, we have to check that the cots are working properly, ventilators, syringe pumps, monitors, suction, everything has to be checked. Then air cylinders, emergency bag equipment. Okay, what happened? I can't see this. For example, say if they say you have to go and pick up a baby who has birth asphyxia, you have to remember, because everything is not included in our standard cot, we have to remember to take the equipment for cooling. Or if there's, say you're going to pick up a baby who is needing exchange transfusion, remember to take the phototherapy light. So like that, we have to think for each retrieval as well, which things you need to take for that particular retrieval. So there are 3 phases to our retrieval. What first happens is there is a call comes in from a peripheral hospital or even a metropolitan hospital, and then there's a coordination center. The coordination center takes the call and diverts it to the neonatal consultant, because the neonatal and pediatric are both done by the same place. And once it's a neonatal one, all of us on the team get the call and they start telling you the history. Sometimes in the middle of them just telling you the history, if they start off by saying, we are calling you about a baby we are resuscitating, the team that is supposed to go out, don't sort of wait to listen to the end of the conversation. We leave the office immediately. So in that journey out where you're actually going to that hospital, that you talk with your nurse and you decide what you might need and who's going to do what and what equipment you want to have ready in hand. And then once you go to that hospital, you take a handover as quickly as possible and you stabilize the baby. And the return journey is to the hospital you're going to bring the baby back to. So I mean, sometimes it might be twins, so sometimes it might be air travel with twins. So we have to think of taking everything for whatever circumstance. So in stabilization, one of the main things in transport is maintenance of normothermia. So I included this photo of the new health bag because this is something they have started using recently. It's a very easy thing to use on a transport because it has the cap and everything. So and maintaining the normal temperature and normal glucose, I think from those are two very important things in transport and two main reasons why there are specialized neonatal transport services in the world compared to each hospital taking their own babies. And I've just given a summary of the main things we have to sort out during stabilization. So respiratory as in hyperventilation or hypoxia, then look at sugar, blood pressure, any other anomalies. Do we have to start antibiotics? And for transport, we prefer not to have the baby given any milk at least for 2 hours. If the baby has been fed, we would empty the stomach because especially some of the flights and even some of the roads in the rural areas are not the best to travel with a full stomach for a baby. And you have to have a safe, adequate IV access. It doesn't necessarily have to be central access, whatever is adequate and safe. And then there will be the specific things for each condition, which I'll talk to you about later. So main things would be temperature, sugar, ventilation, blood pressure, and remembering this NG tube and IV access. So if you're in intubation, as I told you earlier, sometimes you end up intubating a baby you might not have intubated if they were in the NICU, because say you go to some place, you see that a baby is having some significant amount of distress. In a NICU, you might put that baby on to CPAP and watch for a couple of hours to see what happens. But you don't have that luxury of watching for a couple of hours if you're gone for a retrieval. So sometimes you have to balance it and think, okay, there is a higher chance that this baby will deteriorate on the way. So the better thing would be to intubate, and if necessary, they can extubate when we go to the receiving hospital. And especially if it involves a long trip with air travel and you're on the edge of whether to intubate or not, you would err on the side of intubation. And for troubleshooting an intubated baby on the way, I think you all are all familiar with this acronym of this. The E can be very important in transport. So the D, so if a baby who is intubated suddenly deteriorates, so is it a dislodgement of the ET tube, which can happen when you're bumping around in the back of an ambulance? Is it obstruction? Yes, that can also easily happen with even just some mucus plug coming up. Pneumothorax, this can also happen easily, and equipment failure. So now actually one retrieval I went for a couple of weeks ago, we were in the flight, the power went off in everything. So we not the plane, but just the cot and the ventilators. So I mean, at that point, you have your the normal bag and mask ventilation and everything bag ready, but there it was obvious it was equipment failure. But sometimes you have to actually go through the whole list to figure out that it's a equipment failure. But all the other things are also way more likely to happen during transport rather than in a very happy, comfortable, safe NICU environment. So now I'll get on to the specific issues and how we have to handle these. So upper airway issues, what we get referrals for would be choanal atresia, especially bilateral. So in these babies, you can put the good airway, oral airway, and you can strap it down and actually tie it down. But even, and not just have it there, because if you just keep it there, it will come out. So it's important to strap it down, keep the baby nil by mouth, and have continuous observations. Pre-Robin sequence, these babies do better in the prone position for transport, so you can keep them prone and do the transport. But sometimes you might even have to use an nasopharyngeal airway where you just use a ET tube which has been cut short, and for a term baby, that's you put it in about 7 centimeters. And again, you have to observe the breathing pattern continuously. I've said this because even though it seems a very obvious thing, it's sometimes quite difficult to do this in the night inside a helicopter or something. So babies with esophageal atresia with the TOF, these babies are best placed, so we keep them turned onto the right side. So this is to prevent the aspiration as much as possible, obviously nil by mouth, and you have to keep the babies as quiet as possible. So keeping nil by mouth and keeping quiet sometimes doesn't go together. So these are the times when you do get the parents' permission and sometimes give them a dummy to suck on. Because if they start crying, that can cause gastric distension, which can cause you trouble on the way. So because these babies, we try, like if we get the referral early enough and the baby is not in a bad condition, we try to transport as much as possible without intubation. So that's why we take all the steps possible to minimize the need for intubation. And they have to be suctioned. Now, this is very important. At least every 15 minutes, they have to be suctioned. Even if you don't think they are drooling out saliva, and even if you don't think that you can actually hear anything, you have to do it every 15 minutes, because otherwise they will suddenly have a whole lot of secretions collecting and then just aspirate on that. So it's very important that we do the suctioning even during the flight. Every 15 minutes we have to do that. And if we have to intubate, you try to go for a lower position on the ET tip, hoping that you will get past the fistula point. So diaphragmatic hernias, obviously, most of them would already be ventilated and have central lines inserted as well, because a majority of the diaphragmatic hernias would have been diagnosed antenatally, but there are only 2 surgical centers in the whole of Victoria, so they are not all going to be born in surgical centers, but they will be born in at least not the smallest hospitals if possible. But obviously you will have the ones that you had not diagnosed antenatally. Now, in these babies, the current sort of accepted thing is you don't overventilate them. You allow a saturation between 75 to 90%, and the CO2 even going up to 80s so you allow a certain degree of hypoxia and hypercapnia to avoid using high airway pressures for ventilation. And some of them actually do better on low PEEPs, and this is where you avoid high peak inspiratory pressures as much as possible. And if you have the facility, now one type of ventilator we have has the flow time. We have the Fabian on one, so the Fabian has the graphs, but the other one doesn't have. It's just the Stefan, which has only the oxygen and the air. It doesn't have any graphs or any fancy ventilatory modes. So the one that has we usually try to take the ventilator that has the graphs, but the only problem is in all this there are sort of a lot of logistics which we don't think of when we are working in an NICU. Like the Fabian ventilator is too heavy to take in a plane, so you have to take the simple ventilator. So that's why in transport, sometimes you don't have all the facilities and accessories that you would have in a NICU. And especially for diaphragmatic hernia, muscle relaxation and sedation, we use it aggressively during transport. You try not to use too much volume resuscitation, but use an inotrope early, and use a large bow NG which is kept on open drainage. So at least the 8, not 5 or anything smaller than 5. So it is a 8 that is used. And the babies are needing more than 40% oxygen. We do carry nitric oxide. If we know it's diaphragmatic hernia, we use the nitric oxide, and sometimes even prostaglandin too, if you think there is severe pulmonary hypertension. But some things you don't do are to induce respiratory alkalosis by overventilating or use of bicarbonate as a way of reducing pulmonary hypertension. Then pneumothorax. Now, a lot of babies have pneumothoraces which actually don't need drainage most of the time. Some of them, if you just do one-off needle thoracocentesis, you don't, if they're not needing positive pressure ventilation after that, you don't have to actually go and put in a chest drain. But if they do have a tension pneumothorax, you need your immediate needle thoracocentesis. You don't have to wait for X-ray. And remember, if it's a term baby with thick sort of skin and fat, transillumination might not be helpful. But in a preterm baby, transillumination will be very helpful in diagnosing. And a pneumothorax that is not under tension, you might actually not have to, sometimes you don't even have to drain with needle thoracocentesis, but all this depends on how long you're going to have to travel and your mode of transport. And if you're traveling by air, you have to remember to tell the pilot to pressurize the aircraft to sea level, because otherwise what happens is the moment you go above 1,000 feet, the air in any enclosed space starts expanding, and then the effect of the pneumothorax gets worse. So we have to, usually the pilots do ask, do you want the aircraft pressurized? But if they obviously don't ask, it's our responsibility to remember to say we want it pressurized to sea level. Otherwise, they won't pressurize. But if you're using a helicopter, you can't pressurize it. So if it's a pneumothorax, we try not to use a helicopter for that. And the drainage, it's usually the pigtail catheters that are used, but the practice of placing in 100% oxygen is not done anymore for pneumothorax. But there are quite a few, like where we have I just done the needle thoracentesis and not actually even had to transport the baby. We have left the baby in that same hospital with no problem. Or sometimes we have transported by road without doing any drainage, and they have never had to do it, and the pneumothorax has settled by itself. But obviously, if you're using positive pressure ventilation in a baby who has pneumothorax, then you would have to drain it. Sorry, one more thing. Pneumomediastinum, remember, it's no point trying to drain it. So don't try to put drains or needles or anything. So it's important to get an X-ray. Most places can do X-rays, so it's important to get an X-ray and be able to diagnose a pneumomediastinum as a pneumomediastinum so that you don't do unnecessary procedures for that baby. Then that was the sort of respiratory side. Then for bowel obstruction, again, we position the baby to the right side with the head elevated. This is to prevent the aspiration, obviously nil by mouth, against high site NG tube, which will need the intermittent suctioning. And here we have to remember to keep a record of the amount and type of fluid that you are suctioning. So we might even have to replace it on the way. And if there is significant abdominal distension, remember if there can be pneumoperitoneum, remember to pressurize the aircraft. Now, congenital heart disease, many of them are antenatally diagnosed, so then life is easy. They will be delivered in a hospital with cardiac facilities or in a tertiary hospital where they know the baby has the condition, and once the baby is delivered, we just have to go and pick up the baby and transfer to a place with surgical facilities. So for these babies, the main thing would be to have secure IV access, especially for the babies who require prostaglandin. And actually, mechanical ventilation, as in intubation and ventilation, is required only in about even less than 1/3 of these babies. Then there are a few conditions where we have to use special coverings. So, say babies have gastroschisis or examphelos, it has ruptured. So these ones you would have to actually examine, make sure there is no traction, and you might actually even have to untwist it to reduce any traction and ischemia. And you can use the normal cling film what you use, the food grade type cling wrap, but you don't use cotton wool and you don't use warm moist packets. And for the fluid loss, you give an extra 10 ml per kg per hour. Again, you have to put the NG. Meningomyelocele, if they are ruptured, you just use a sterile dry dressing and obviously nurse prone. And you might you can use a foam rubber like a donut shape thing. You can put it around the lesion so that nothing, even if you have if there is a dressing over it, it's not going to touch, and or the baby turns accidentally, it's not going to harm the meningocele, sorry. So ectopic bladder, again similar to examphelos. Sacrococcygeal teratomas, again same, and because it's obviously on the back, you keep in prone or lateral position. Epidermolysis bullosa, they have some, they call it a pack of a special pack for this, but basically it is just silk sheets that they use to cover these babies with for the transport. I thought I'll tell a little bit about retrieval and COVID. It has been a big nuisance because we do the smaller bronchiolitis babies as well. So it is a big nuisance if you have to do it under COVID precautions, because one thing, you have to get into this full kit that is shown here. And if you're intubating, you have to have glasses and goggles and another face shield as well through. So you're trying to intubate with 3 things in front of you. And then if you're going to have to listen to the chest of a baby or listen to the heart of a baby in this kit, you have to have the stethoscope over this, and you can't hear anything, basically. So it has made life a bit difficult when we have to do, I mean, even some of newborns we have had to do in the full kit because the mother was suspected to have COVID, and that made life a bit difficult. And the biggest change has been that, I mean, in neonates, we have never used cuff TT tubes up to now. We have had to use cuff TT tubes to reduce the transmission to healthcare people. So that has been a new thing because none of the neonatal doctors or nurses were very familiar with using cuff TT tubes. And then you had to inflate the cuff and measure the cuff manometer pressures and things. And I have just included a like a flow chart which was prepared to show the things you need and the people you need if you're dealing with a baby who's suspected to have COVID, or the mother is suspected to have COVID. But although there's this whole list of people you need, and sometimes in some hospitals you just don't have enough people, even in the whole hospital, to fit into all these roles, and you have to learn to do with what is available there. Right, so now I'll get on to the case scenarios. So in this, I mean, I'll give you the history and then the diagnosis and what you would like to do for the management. You can think about it and type it, or you can tell, or just think about it, and then I'll go on to it after giving you a little time to think about it. Okay, so there was a call from a private hospital at 6 o'clock in the morning saying a day 2 baby girl was found to be floppy and cold at 36 hours of age. I mean, that's all they started off the call with. So what other information would you like to know? Because the call came from the, I don't think there was a doctor there at the time. I think the nurse gave the call. So just think of what other information you would like to know. I mean, there's a lot of information you would like to know. And based on those, what would be the possible diagnosis you would think of and how you would manage. So if anyone wants to just think of what else you would like to know, you can type it or say it or whatever. I'll just give you half a minute and go on to the next one. Because you get the phone call and then you have to ask the questions, because usually when you get the call from somebody who's not familiar in making a referral to the retrieval service, you have to get all the information from them. Okay, so shall I just go on to the next one?
Madam, can you see the text box?
No. How do I see that?
One doctor said weight and gestational age, temperature, CBS, risk factors of sepsis.
Sepsis. Okay, good. Right. So I'll go on to the next slide, which will have the answers for most of those things. Yeah, weight, I think weight was 3.2 kilos. So it was a term baby, uncomplicated pregnancy, except for being positive for group B streptococcus, rupture of membranes for 12 hours, but the mother had apparently received 3 doses of IV penicillin during labor, so that was taken as adequate cover. It was a normal delivery, APGAS 899, no meconium, was well on the first day and was actually waiting to be discharged on the, like they call at 6, they were actually waiting to go home by about 9 o'clock in the morning. From midnight, there has been some difficulty in feeding, but I think somebody has said it was a nasal block. It's winter, it's cold. So, but it was the father who actually felt that the baby was unusually cold and had alerted the nurses. So just think of what would possible diagnosis. And what you now think. We are also getting this information over the phone. And we also have to try to visualize a baby and think what is going on, and because we are also supposed to provide some advice. How do I get to see what is being typed?
Madam, when you get the cursor into the screen, like near your hand raising button, you have a small kind of a text like cage.
Yeah, but when
you present, you will not see it. Is that so?
I think
So one doctor has said baby's hemodynamic status, including pre-post ductal saturations.
Okay, so these were the examination findings. Lethargic with poor tone. So the pre-ductal was 85%, post-ductal was 80% in air. Temperature 35.6, respiratory rate was 70, heart rate 170, no significant recessions. Cap refill time was 3 to 4 seconds. Mean blood pressure, I think they couldn't get it properly. They tried, but then so it's something like 28. There was no murmur, but they were not sure whether the femorals were weak. Chest was clear and fontanelle was flat. There's normal genitalia and palate, and the sugar was 2 something. Yeah, just over 2. Now, what are the things you would think of? How come I can't see this? I think when I'm on full screen, I can't see.
You will not be able to see. Yeah, that is. So we'll find a way. Maybe it will be helpful for the next one.
No, if I come out of this, it's not going to be here. That's okay. Oh dear, what did I do? Okay.
You have to go again for the full screen mode, ma'am.
I'll get back to it. Okay, so any thoughts about possible diagnosis? Common things are common.
Congenital heart disease with duct-dependent circulation, neonatal sepsis.
Yeah, okay. So, yeah, sepsis and cardiac were on top of the list, definitely. And there was the possibility of, it's a bit early, but CAH and metabolic 36 hours is a bit early for those, but really possible. So the thinking of these differential diagnosis, we asked them to do as much of these investigations as possible. And for this baby, by this time, the team had already left. By the time the call was still going on, even at the time the team arrived at the hospital. So we asked them to try and get a blood culture if possible, blood gas, blood sugar, and other bloods if possible. And also because they have to call X-ray in, they don't have on-site radiographers, they had to call the X-ray person to come and do it. So to do as much as possible of this. And yeah, so sorry, I went on to the next one. So management-wise, what would you recommend? Remember, the doctor is still on the way. We are still on the way. Their doctor is still on the way. And this is a nurse and a midwife on duty who's calling you. What would you ask them to do? These hospitals do have non-invasive ventilatory support available most of the time for a short period. There weren't any significant recessions. Anything you can suggest? Okay, so what was suggested by the neonatal consultant at that point was to start on high flow oxygen until a person.
Excuse me, madam, one doctor said oxygen high flow.
Yeah, so that's exactly what was done. So good. So to start on high flow oxygen until someone's killed in intubation was available. And then our team prepared for the pre-medication drugs and everything on the way, including some doses of adrenaline boluses as well. So they said IV access was difficult, so they were told to try for a UVC, but I think meantime their pediatric consultant also came and was able to get the peripheral line in. So they had given 2 normal saline boluses by the time we got there. Dextrose bolus was also given and infusion was started. Antibiotics were, I think, given as the team arrived. And they did start they were also advised to prepare an adrenaline infusion and keep, which is you can give peripherally in an emergency situation. And the next question was, okay, so remember cardiac was our second differential diagnosis. So do you give prostaglandin? Do you give bicarbonate? Because the next blood gas was worse than the one we saw earlier. It had a pH of 6.8 with bicarb of 7. But what they gave they gave 3 more boluses of normal saline because once the team arrived there, they felt this was more sepsis rather than cardiac. So 3 more altogether, I think nearly 5 normal saline boluses had been given. And inotropes were also started, after which the pH did come up and we didn't have to use bicarbonate and we didn't have to use prostaglandin at that point, because actually after a couple of boluses, the femoral pulses were felt adequately. So because of that, they didn't rush and give the prostaglandin. So this tells you the type and the type of story you hear, and the thing. Now you can't ask them to intubate the baby when you know there's nobody there who can actually do it, and there's a limit. And this was actually a hospital close to the center, so it took only about, I think, half an hour to get there. But I mean, it can happen in a place that takes 3 hours to get there as well sometimes. So this baby, however, ultimately had a, I haven't put the final diagnosis here, had a coliform sepsis, I mean, it wasn't GBS, it was a coliform sepsis with meningitis, and the baby is in, I think, quite a bad state at the moment with lot of changes on the MRI as well. And I think they might actually withdraw the baby. Right. So second one, this was from a district hospital. This case, I'm just telling you about some other equipment we might have to think of. A 36-week baby, 2.1 kilos, was 5 hours old. So IUGR baby, 5 hours old with respiratory distress and oxygen requirement that is going up. Now that's sort of the opening statement we were given, and the rest of it you have to keep asking them. So they say they're currently on CPAP of 7, otherwise okay, and on IV dextrose. So when you get a call like this, it's not like seeing the baby in front of you. Even if they say otherwise okay, especially when you're making a referral, when you're calling and telling somebody about a baby, remember it's better to talk in numbers. Like say respiratory rate is this much, saturation is this much, heart rate is this much, because then it is very easy for the person on the other end to actually visualize, rather than, because okay for one person might not be actually okay for the other person. So what are the other information you would like to obviously know would be the observations in objective terms, and they could get a chest x-ray. So chest x-ray, blood gas, blood sugar, and antibiotics were recommended. So this baby, I think now although they said was on CPAP and oxygen going up, they didn't actually tell how much. It was CPAP of 7 with 40% oxygen at the time they called, and it was going up. It was 60% by the time the retrieval team got there. So obviously they decided to intubate, but it was a difficult airway. So these are the situations where you have a lot of trouble. You're not in a big hospital. You don't have anyone else to. Usually, you don't have anyone else as a backup. In this situation, they did actually have a anesthetist who had some pediatric background in the emergency department or somewhere else in the hospital, but most of the time you don't have that backup. And the problem was that they could visualize the vocal cords but couldn't actually get the ET to go through. So the team that went, the anesthetist, the local pediatrician, they all had several attempts, but they couldn't get the ET in. In between, they managed to maintain oxygenation using the Neopuff. So what would you do in this situation? Now you have a baby who has a certain degree of respiratory distress that is warranting intubation, but you can't get a tube through. What do you do? And you have to transport this baby. What are the airway adjuncts, or what can you use in a situation like this? I can actually see it on my other computer. Okay.
Then you can read it, madam.
Yeah, I can see it on the other one. So cricothyroidotomy, laryngeal mass, tracheostomy, all good suggestions. What do you think we would prefer to try first? Obviously the non-invasive things.
Laryngeal mass के आगे?
Yeah, definitely. So baby was ultimately transferred with a laryngeal mask airway, and I just wanted to bring, and this baby ultimately went straight into theater with the ENT people ready to do tracheostomy if it was necessary. So baby was taken straight into theater, but and was found to have a laryngeal web. So I just put up a diagram of like for any intubation, whether it is elective, emergency. I mean, these are the, especially in our transports, we have like what we have to do is before we start our intubation, we have to have our plan A, B, C. So the plan A should be, okay, I'm going to try maybe with the introducer if I want to introduce, and I will ask the assistant to give cricoid pressure if necessary. And if same person usually tries only twice, but even the 2 attempts, there should be some difference in the 2. Like you can't do the same thing the second time. So say first time you tried with the introducer, second time you can try without if you think that might be, but if you think it will be helpful, or second time you might reposition, use some support between the shoulders or something. So even if you're going for the second attempt, make sure you change something. And the other thing is that you actually, now especially when you're on a transport, you're working with different hospitals teams who don't know you and who don't know your nurses. So you have to verbalize and say, okay, you have to tell me to stop when the saturation drops below, say, 80, or the heart rate drops below 120. I mean, depending on what it is. If you're trying to intubate a baby with saturation of 50, you can't tell that. But provided you have been able to pre-oxygenate well, you have to set your limits, verbalize it very clearly, loudly, and then go ahead with it. Because remember, you're not working in a familiar environment. So plan A was, I mean, the retrieval doctor tried. Plan B, they got even the anesthetist to try, and then when both did not succeed, they went on to the laryngeal mask airway. What's the lowest gestation you can use a LMA? Any idea? Weight and gestation. It can give you a very secure airway if you can't get a ET in. So if you have a size 1 LMA, you can use it in a baby down to 34 weeks or 1.5 kilos. So above 34 weeks and 1.5 kilos, you can use a LMA. And it is very secure even for transport. And even a lot of surgeries are now like the short surgeries, things like biopsies and things are done under using LMS rather than intubations now. So I just found this chart. I thought I'd put it. So these are the preparation things, and then what you use for the first attempt, second attempt, and then LMA, and finally cricothyroidotomy or tracheostomy if ENT team is available. Okay, so the last scenario. Yeah, we'll do it quickly. We have about 5 minutes more. So we got a call from a regional hospital saying, please come and take this baby as oxygen saturation is not rising above 70s. So that is all they told us. They said, just come. So we had to actually calm down the person who gave the call and start asking some questions. So the background was, it was a 38-week baby, normal scans, no risk factors for sepsis, had needed some resuscitation at birth, but from 10 minutes onwards had been breathing by herself, the baby, and had only needed CPAP, but needed 100% oxygen. Respiratory rate was between 70 and 80. Postductal Now the 70s was the postductal was 78 and preductal was 99. And when you question, they said even if this oxygen is 40%, it's like this. Even if it's 100%, these are the same saturations. So what else would you like to know? We were just given that first sentence. We got the rest a little bit more. Anything else you would like to know? Just think of what your possible DDs would be. Femoral pulse, good. Well, they said femoral pulses were probably weak. Remember, this whole team was very anxious. Anything else you can do? What would be the differential diagnosis? MAP, yes, certainly. MAP was, I think, it was over 40. It was about 42. Anything else with blood pressures you can do? If you think of the possible DDs. And if they are saying femoral pulses are weak. Yeah, definitely falling blood pressures. Okay, so obviously the different, yeah, okay, I pressed it by mistake, that's okay. So the differential diagnosis were a cardiac cause could be severe coarctation, and the other biggest possibility was PPHN, which is persistent pulmonary hypertension. And remember, PPHN can be due to several reasons. It's not always just one problem there. So yeah, your femoral pulses, yes, falling blood pressures, heart sounds, side, murmurs. Remember, there are other causes of similar PPHN type picture. Liver, dysmorphisms, chest X-ray and ECG if possible. So the two main DDs we had were PPHN. The things for PPHN were that this baby had needed some resuscitation and was probably just having some delayed transitioning. And the other thing for PPHN was that the preductal was actually 99%. So those were for PPHN. But then when you ask, they said femoral, they are not sure whether the femoral pulses are easily, they say femoral pulses are probably weak, and they even said the liver might even be 5 centimeters. So obviously when they said that, we got the cardiology people also involved in the phone call, and they obviously advised to start prostaglandin. But remember, what are the biggest dangers of starting prostaglandin? I mean, this hospital was okay. They could probably deal with starting prostaglandin. But what are the things you should think of before you start prostaglandin? What are the side effects that you can have? Yeah, so the biggest immediate one would be apnea, hypertension. So there should ideally be somebody capable of putting a tube in if you're going to say start prostaglandin. And I mean, just for the sake of your information, I put the long-term things as well. Like there are some situations where you have to use prostaglandin for long durations, and then you can have even situations similar to pyloric stenosis. It's not here, it's just for your knowledge. And the other, because now they were saying that for whether they use 40% oxygen or whether they use 100% oxygen, there was no difference. We advised them to reduce the oxygen as much as possible, aiming for pre-ductal saturations of more than 94 and not to bother too much about the post-ductal. Right, so, well, it was a 2-hour journey, and throughout almost these 2 hours they were on the phone. But to cut a long story short, by the time we got there, the baby was in CPAP of 6 in air with saturations pre-ductally 98% and 92% post-ductally. And prostaglandin was not without starting prostaglandin. And when I examined the baby femoral pulses were easily palpable. There was no enlarged liver. So we ultimately did not even transport this baby. We took the CPAP off, waited there for about an hour or so, and the baby was fine, so we didn't bring the baby. So it was PPHN because of the delayed transitioning that happened because the baby needed some resuscitation at birth. But remember, PPHN can be due to several reasons. It's not straightforward, just increase in pulmonary arterial pressure. There are other things that contribute to it, like lung problems, lung expansion issues, cardiac function. All those do contribute to this. So you shouldn't just think of it as purely elevation of pulmonary arterial pressure. You have to think of the other things as well. And there are the sepsis, pneumonia, all these other causes, lung pathologies which can cause pulmonary hypertension as well, and we should treat those as well. So just one quick slide to finish off with management of PPHN, or which is better called possibly delayed transitioning. So aim for saturations more than 94% pre-ductally. You treat any underlying cause, whether it's sepsis, pneumonia, whatever, hypothermia, hypoglycemia, all those can contribute. Ventilation, you should use the lowest effective mean airway pressure. So that is why you sometimes tend to use high frequency, because there you can use lower mean airway pressures. Inhaled nitric oxide would work best if the pathophysiology of that particular baby's PPHN is mainly raised pulmonary arterial pressures. You should have adequate systemic blood pressure, adequate sedation, muscle relax, especially for transport. We would definitely muscle relax. And if everything else is failing, the baby with PPHN would be transferred directly for ECMO. That's it.